Hey, last time I discussed about laryngomalacia. In this lesson, I will discuss about subglottic hemangioma, papillomatosis of the respiratory tract, vocal nodules, and subglottic stenosis. To start from the congenital subglottic hemangioma, in the case of subglottic hemangioma, symptoms typically present with the first 2 to 6 months of life. And the most common presenting symptom is biphasic stridor, somewhat more prominent during inspiration, and this is exacerbated by crying and acute viral illness. A barking cough, hoarseness, and the symptoms of recurrent or persistent croup are a typical symptom of this problem. Only 1% of children who have cutaneous hemangiomas will have a subglottic hemangioma. However, 50% of those with a subglottic hemangioma will have a cutaneous hemangioma. Treatment options for hemangioma of the respiratory system range from conservative monitoring, steroid injection to tracheotomy and airway reconstruction. Propranolol has become a mainstay in initial therapy of subglottic hemangioma. However, it's estimated that up to 50% of patients with subglottic hemangioma may not have a long-term response to propranolol, indicating a need for close airway monitoring in this patient. The second is respiratory papillomatosis. Papillomas are the most common respiratory tract neoplasm in children, occurring in 4 in 100,000 newborns. They are simply warts, benign tumors, caused by the human papilloma virus, most commonly type 6 and 11. 75% of recurrent respiratory papilloma cases occur in children younger than 5 years of age, but the diagnosis might be made at any time. In general, neonatal onset disease is a negative prognostic factor with higher mortality and the need for tracheostomy. 67% of children with recurrent respiratory papillomatosis are born to mothers who have condylomas during pregnancy or parturition. Despite close association with vaginal condylomata, only 1 in 200 to 400 vaginal births go on to develop respiratory papillomatosis. Therefore, other risk factors contribute to transmission, and C-section delivery for prevention cannot be recommended. However, preventive measures can include the prospective widespread use of the quadrivalent human papilloma virus vaccine to help eliminate maternal and paternal human papilloma virus reservoirs and possibly decrease cases of recurrent respiratory papillomatosis caused by human papilloma virus 6 and 11. Regarding the clinical manifestation of respiratory papillomatosis, the clinical course involves remission and exacerbation of recurrent papillomas, most commonly on the larynx, usually the vocal cords, causing progressively worsening hoarseness, sleep disordered breathing, exertional dyspnea, stridor, and if left untreated, eventually severe airway obstruction. Although it is a benign disease, lesion can spread throughout the aerodigestive tract in 31% of patients, most commonly the oral cavity, trachea, and the bronchus. Rarely, these lesions can undergo malignant conversion. However, some patients might have spontaneous remission. Patients might initially be diagnosed with asthma, croup, vocal nodules, or allergies before the appropriate diagnosis is reached. When we see the treatment for recurrent respiratory papillomatosis is endoscopic surgical removal with 3 goals. Those goals include, first, debulking and complete removal of the lesion. Secondarily, preservation of normal structures, and finally, prevention of scar formation in the affected areas. Adjuvant therapy might be needed in up to 20% of cases. The most widely accepted indication for adjuvant therapy are a need for more than 4 surgical procedures per year, rapid regrowth of papillomata with airway compromise, or distal multi-site spread of disease. Adjuvant therapies can be inhaled or administered intralesionally or systemically and include antiviral modalities, anti-angiogenic agents, photodynamic therapy, dietary supplements, non-steroidal anti-inflammatory drugs, and retinoids, and also mump vaccination. The other is vocal nodules. Vocal nodules, which are not true neoplasm, are the most common cause of chronic hoarseness in children. Chronic vocal abuse or misuse, such as frequently yelling and screaming, produces localized vascular congestion, edema, hyalinization, and epithelial thickening in the bilateral vocal cords. This grossly appears as a nodules that disrupts the normal vibration of the cords during phonation. Vocal abuse is the main factor, and the voice is worse in the evenings. When we see the treatment of vocal nodules, treatment is primarily non-surgical with voice therapy, used mainly in children greater than 4 years of age who can participate in therapy, and the clinical monitoring with behavioral therapy in younger children or those with developmental delay. In addition, laryngopharyngeal reflexes are common. They commonly exacerbate vocal abuse, induced irritation of the cord. Therefore, anti-reflex therapy can also be implemented. Surgical excision of vocal cord lesions in children is controversial and is rarely indicated. The final topic is subglottic stenosis. Regarding the clinical manifestation of the congenital subglottic stenosis, congenital subglottic stenosis is the second most common cause of stridor next to laryngomalacia. The subglottis is the narrowest part of the upper airway in a child and is located in the space extending from the undersurface of the true vocal cords to the inferior margin of the cricoid cartilage. Subglottic stenosis is a narrowing of subglottic larynx and manifests in the infant with respiratory distress and biphasic or primarily inspiratory stridor. Symptoms often occur with a respiratory tract infection as edema and thickened secretion of the common cold, narrow and already compromised airway leading to recurrent or persistent croup-like symptoms. In a child with recurrent bronchiolitis, diagnosis of congenital subglottic stenosis should be considered. The stenosis can be caused by abnormally shaped cricoid cartilage, by tracheal ring that becomes trapped underneath the cricoid cartilage, or by soft tissue thickening caused by ductal cystis, submucosal gland hyperplasia, or fibrosis. Acquired subglottic stenosis refers to stenosis caused by extrinsic factors, most commonly resulting from prolonged intubation. Regarding diagnosis of this problem, the diagnosis is made by airway radiographs is confirmed by direct laryngoscopy. During diagnostic laryngoscopy, the subglottic larynx is visualized directly and sized objectively using endotracheal tubes. The percentage of stenosis is determined by comparing the size of the patient's larynx to a standard of laryngeal dimension based on age. Stenosis more than 50% is usually symptomatic and often requires treatment. Regarding treatment of the subglottic stenosis, as with all cases of upper airway obstruction, tracheostomy is avoided when possible. Anterior cricoid split or laryngotracheal reconstruction with cartilage graft augmentation is typically used in severe subglottic stenosis. The differential diagnosis includes other anatomic anomalies such as hemangioma or papillomatosis. This is all what I have regarding those 4 problems. On the next topic, I will discuss about other causes of stridor in the newborn. Thank you for watching.